Good evening, everybody. Welcome to this 20th session of 51st course of echocardiography. We're here from Jorop Institute of Echocardiography. We welcome you all to this particular program. As you know that we are established in Ashok Vihar, Delhi. This is our auditorium where you're likely to have your hands-on training in due course of a time. The legends behind this training program is none other than Dr. SK Parashar, who is going to take our cyanotic congenital heart disease. Apart from our international president, Dr. Naveen C. Nanda, and our dear Dr. SK Chopra and Samir Srivastav, and Dr. Hansa Gupta, who's along with us in these training programs. Two names which you'll hear again and again. One, you must have heard about Mrs. Rina Dua. She has been coordinating with you all the times. And when you come for a hands-on training, Dr. Narang takes care of a local hospitality. We have many accreditations from Indian Academy of Echocardiography, International Society of Cardiovascular Ultrasound, Alabama, Delhi Medical Council, CDM of a Northwest State or State Appropriate Authority for doing a hands-on session during these training programs. We are running 1-year fellowship program with Parul University, and last year we could train about 7 to 8 students, technicians for this BAPU Training Academy. Out of that, 3 have already got placements in UK. They have joined as technicians already. We can boast of saying that we are the largest institute in India providing state-of-art hands-on training. We started this concept under the able guidance of Dr. SK Parashar, and today we have trained more than 5,000 people in this particular program. We have completed almost 25 years of establishment. We started the program in April 2000, and we have completed this in 2025. And this is what in 17th August, we celebrated our 25 year of existence in Ashoka Hotel. You can see all the legends standing over here, including Dr. Col Parashar, Dr. SK Chopra, Dr. Samir is not seen over here. He's Dr. M.K. Das, Dr. Manish Bansal, Dr. Chabra, and in many legends. We have an international faculty, Dr. Mubarak Rashid, along with Dr. Rawat Bhatta from Nepal. This is one photograph of the world first conference which we did, first Cardio Echo Metabolic Symposium on 17th August 2025. Well, many logos which has developed over a period of time. We started with one and now this is one we started with, and we have developed many logos over a period of time. And this program is going to have a hands-on session as we declared earlier, October 30th to 2nd November. And those people who have registered and completed their attendance, that's the most important thing, they're likely to join this hands-on training program for 4 days. With these few words, let me request Col Parashar sir to dwell on this 20th session of cyanotic congenital heart disease, and I've already dealt with basic cyanotic heart disease. This is Dr. Parashar, who is the past president of Cardiological Society of India. He has been the past president as well as a founder of Indian Academy of Echo. He has been bestowed with many Lifetime Achievement Award, and the most important award which he got is from our own president, President Shri Abdul APG Kalam earlier. He is the co-author of the 2nd edition of IE textbook of echocardiography, and is an emeritus editor of one of our book, 3rd edition, which is just published. Apart from many small documents, small text, ready documents, which we have published over a period of time, and a posters. With these few words, I will request Parashar sir to take his class, and I'll stop sharing my slides over here. It's all yours, sir. You can share your slides.
Thank you, thank you, thank you. So as the title says, common cyanotic congenital heart diseases. Nowadays, many of the cases are being dealt in their infantile stage or when they are young. So many of them may not reach as a present as a common cyanotic disease because they are treated in early stages or so. But those are very complex cases who directly go to the pediatric centers. So we are not concerned with that. But some congenital lesions which we see in adult stages and which you all will see sometime in your career, we'll discuss only those ones or so. Now, as I told you that earlier also, that every echo has a clinical information, anatomic information, and hemodynamic. Anatomic by 2D echo and hemodynamic by Doppler and then by clinical information. I won't give you much example also, but you see this is a short axis view, right atrium, right ventricle, and the short axis via the pulmonary artery. But we don't know the history. Somewhere it was missed as a foreign body or something or so. But when we went into the history, then we came to know that it was a device closure of the patent ductus arteriosus. Probably we did not see that much before, but this was one of the cases that it was a device closure. So that is the importance of taking a history. Then this was a 50-year-old lady who was being treated as a case of a dilated cardiomyopathy. You see the LV is significant and large. LV functions are deranged. But when we went into detail, also including clinical examination, we found that the patient had a patent ductus arteriosus. You can see the flow going from the descending aorta to the pulmonary artery. And on a Doppler, you can see there was a continuous flow. So this clinical information completely changed her outlook from a non-treatable condition to a treatable condition. So this is the example of always, irrespective of congenital heart disease, any case you see, start with a brief clinical history, ECG, X-ray, and the past history, so that you can get some information what you want to see. Now you see sometimes, no, this has already been discussed, but when we do an ESD, any structure which is brought close to the transducer is seen better. So this was a modified apical view. We brought the structure more closer to this transducer, and we saw that there were two ESDs in this case, one here and one there. Now, which we could have missed when we did a conventional two-chamber, four-chamber view, but this is now broadly viewed. This I take it for seeing an ASD, and this is of course you see. Sometimes you see very small ASD, and you can see with the color also. So you can not miss if you go everything you see structure-wise. Although apical views are not that good for ASD, but that you can see. Now coming to the subject proper. eh, this cyanosis is usually what we are concerned is a central cyanosis. Central cyanosis means that there is a right to left shunting. And when there is a shunting from the unoxygenated blood to the oxygenated blood, there is a cyanosis. So that in every case, we should be able to demonstrate a right to left shunt. Peripheral, we don't know. This was sort of a Raynaud's phenomenon. We are not concerned. Differential, we don't see so much nowadays. Otherwise, you can see a immediate pulmonary hypertension. They have got the pink upper arms and their legs are toes of the cyanotic. So there's a differential cyanosis, but being there early, sometimes you cannot see, but always see for a cyanosis in upper and the lower fingers, how we'll tell you just now. So we are mainly concerned with this. Now, in my talk, anytime you have any problem, you are free to ask. Don't wait up to the end of the lecture. Otherwise, you will not know what you wanted to ask and you will forget about it. Now, there are some common nomenclatures. The situs solitus, levocardia. Levocardia means that the cardiac apex is to the left. Situs solitus, dextrocardia, as you know, is the cardiac apex to the right because the heart is shifted to the right side. So it is a cardiac apex to the right. Situs inversus and dextrocardia. That means body organs are reversed and apex is to the right. So this is situs inversus, that means the body organs are reversed, and dextrocardia means apex is to the right. So same thing is in other things also when we say levocardia. Levo means cardiac apex to the left and dextro means cardiac apex to the right. Now, what I was telling you is every case, you always use a pulse oximeter. That is the basis of all echo examinations, especially a congenital heart disease, whether it is cyanotic or a non-cyanotic, a pulse oximeter is there. So that is why integral, it in increased path. And what I say, check both fingers and toes. So that means if there's a differential cyanosis, you can pick it up. You see the oxygen saturation in the fingers and in the toes. So that will tell you about a reverse shunt. And we always write a value in the report that is at the time of the study, the oxygen saturation was so much in the upper and the lower. So that is always mentioned there. So you should have a pulse oximeter every time available with you to see this. So that sometimes you can miss a mild cyanosis and other things also. Some patients get low cyanosis on exertion, so immediately check the finger and toes that give you you know that you are dealing with a cyanotic heart disease. Now, so these are other things when you see a cyanosis, you see whether it's central, you see for a clubbing of the nails, all these things you see, and you see the various things you see when you know these, what are the murmurs and what this. One thing is that the manifestations of heart failure differ from the adults. So when we say heart failure, that means they are high risk cases. For example, these are the failures, heart failure, but they are also high risk patients. These patients will be immediately sent to a cardiac center, also pediatric. That means when the patient has a poor feeding and failure to thrive, this can also be a sign of a heart failure in these cases, and it is a poor prognostic side. A respiratory distress, a marked dyspnea, a tachycardia more than 120, and sometimes the mother says that when the child cries or is feeding, he gets an excessive perspiration. So and the pulmonary disease. So these are all the signs of a high risk infant, and they can also be a indirect evidences of a heart failure. So poor feeding and failure to thrive, respiratory. That is why you always ask a history from the mothers as to what is this. But here we are in the adults, so we can ask from the patient respiratory distress, tachycardia, unexplained, excessive perspiration, pulmonary rales or bees, and cardiomegaly, or sometimes the pericardial fear. So these are the high risk or heart failure patients. So, so now number one important point is you should have a basic knowledge of anatomy and physiology. Unless you know what you want to see, how can you diagnose? Suppose I say follows tetralogy. You do not know what are the four things to be seen. So how can you diagnose and how can you see? So any structure of a common congenital heart disease in adult cyanotic, always see for a basic knowledge of anatomy, physiology, and the blood flow also. Then always, these are some of the, when you see a small child up to a age of 3 years, 4 years, they create a lot of problem. So in adults it is different, but they create a lot of problem. And these patients we give a trifluoral 50 to 100 milligram per kg weight. So this is mostly restricted to young children, maybe about 3 years, 4 years or so. And then you do a quick segmental approach, which has been told to you. Always look for multiple lesions, never be satisfied with one lesion. So the basic important thing is have a small notebook, put the name of the disease and what are the main anatomical features and what is the blood flow. Always make it also. And then always demonstrate a right to left shunt. So these are the basic points also. In adults, it doesn't matter, but in children, it is very difficult to do an echo unless they are sedated. And what we do is the child should be covered with a blanket or an infant, and their clothes have to be removed first. Otherwise, when they are sedated, then you see that and then you remove the clothes. They are awake, and so you cannot do all this thing. So the problem occurs. Many of the children, they sleep in the car when they are coming. So when they come, they're fully awake. So you should have a lot of patience. So normally when we call at that time, when we have got more of an adult patient, so that they can wait. So, so again, I told you this, all this thing, and then saline contrast echocardiography, which you must see when you come for a hands-on training. So the basic principle of it's a very useful technique despite color flow mapping. The basic principle is that you take a certain amount of glucose saline, and that depends upon the age of the patient. You take two syringes, you put glucose saline in one syringe, push through a three-way cannula to the other syringe, so go on alternate pushing or so till they become almost white with the air and relative putting. So the basic is that you mixture them. You can use your blood also, but the technique is there. Upon on the gauge, you put a large bowl cannula. You send this from one syringe to other, and those they become a milky white or so. So that is time, and that will be shown to you during your workshop, and then it is injected. Now, how does it look like? Now, you remember my LV is on the left side at LA. So you see, this is the RVRA. Now, what happens? You have given a glucose saline. The ultrasonic beam comes and strikes against these micro bubbles and produce a contrast effect. So you see, it is just like this. Very nicely you can see. So when these micro bubbles go to the pulmonary circulation, because they are of a larger size, they are destroyed there. So that none of the left-sided structures are opacified, because they are larger than the pulmonary capillaries, so they are destroyed there. So they go to the RA, they go to the RV, opacify them, and when they go to the pulmonary circulation, they are destroyed. So you don't see any opacification of the left side. Now, suppose there is a communication between the right and left, then it will cross there. That will show just now. This is a normal contrast echo. Now, see, this is a patient. You see, this is a BSD. Now, apparently, the BSD is here. So you know there is a large BSD. So when you give a contrast, you see, it goes to the RA, RV, and from RV, it goes to the LV. So there is no contrast in the right atrium. So that means it has gone from the RV to the LV, a right to left shunt by a contrast echo. So this is just for a demonstration purposes. But sometimes when your color flow does not help you, because being adults, in its children it is all right, but in adults you may not see. So just to show that how, so this has bypassed the pulmonary circulation, and so that it has gone directly into the right ventricle, producing left ventricle, producing a contrast effect. So similarly, you see, this is a sort of a. I'll show you later on. You can see this is a right to left cell. We want to see. We have injected a saline. It goes to the right ventricle. From the right ventricle, it goes to the left ventricle and goes to the aorta. Because this is a case of a fellow tetralogy, will show you just now. And in fellow tetralogy, the RV pressure may be high also. So it opacifies the right ventricle and goes to the LA and then into the LV and then into the aorta. So this can be seen in all the views. Wherever that particular structure is seen, you can see whether it is subcostal, short exit, anywhere you see this contrast effect you see. Similarly, you see, here you see, now this is large RV, large RA, small LA, small LV, and possibly a AST septal defect. Now, once you give a contrast, you see at the atrial level, it goes from right to left. So that means there is a right to left shunt at the atrial level. You see, it go to the right atrium and get bypassed directly into the left atrium, showing a right to left shunt. So these are just common examples of a contrast echo. How does it help us and how does it look like? And it is just a little bit of a glucose saline or so. Now, anytime you can go and ask any questions. Now, any question till now? If no, then we go to the fellow tetrol, because you should not go with any doubt. So whatever we have told you till now, if there is any doubt, you get it clarified now. Now, we come to fellow tetralogy. Tetralogy means 4 lesions. Tetra, 4 lesions. And we, as usual, in every case where in echo we do a 2D color flow mapping, Doppler features and other basic lesions. Because color will give you additional information, and it puts you, the Doppler is you put parallel to the flow when you can see the color. It is the commonest cyanotic heart disease you will see in adults. It is the commonest one we see in adults who have not been treated at the earlier stage because of economic reasons or any other things. So now tetralogy means four things. It has a ventricular now this only shows that we do all the views, do not restrict to one view. There is a ventricular septal defect, aortic override, RVOT obstruction, RVH. Why? As I told you before, any chamber which is subjected to increase the pressure or a volume overload or pressure overload thickens. For example, in aortic stenosis, you get a thickening of the LV. Pulmonary stenosis, RV, because a chamber which is subjected to increased pressure always increases in thickness. So these are the four things you see now. This is a normal one. This is a normal parasternal long SSU. You just see that this is the anterior wall of the aorta, posterior wall, and this is the interventricular septum. And they are in the same line. There is the same continuity in a normal echo. The anterior mitral leaflets is in continuation with the aorta or the aortic wall, as you see here, and the septum is in anatomical continuity with the anterior wall of the aorta. So this is a normal thing. So if you get an idea of the normal thing, now you see. Now you see what happened, what I showed you. Now here you see there is a BSD, large BSD. There is an aortic override. It is not there. Now see, compare with this. Here the aorta and the septum are in the same line and there is no BSD. But here you see this is a large aorta, which is this is the RV, LV, there is a ventricular septal defect. As you can see the RVS. So this is sometimes also known as a biventricular origin of aorta. Biventricular means it arises also from the right ventricle and the left ventricle and is one of the commonest cyanotic heart disease. So you just go on forming an idea of the image because we'll show you mostly images we will show you. Theories you can read anywhere. So you see this is the septum, this is a large ventricular septal defect. There's an aortic override and the RVH will be there. We'll show you sometime. So now see, this is another VST, but there's no aortic override. So you see, this is the aorta, this is this is the VST, but there's no aortic override. So this is a simple VST and not a VST associated with with a cyanotic heart disease, because here you see they are in one line. The one line is no aortic override as compared to this. You see, it is completely overriding. So again, you see here there is no overriding. And similarly, you can see various, now again you see a VSD and you can see a certain amount of overriding also. Again, you see that white is known as a dilated aorta with overriding. You see the aorta is dilated and it overrides this. Override the ventricular septum. It should be normally more than 40 to 50% because the small override you can produce yourself by abnormal imaging. So you should now get an idea of a VSD, aortic override, and the other thing we'll show you. Now again you see short axis view, you see a large VSD. So you are the septum, wherever septum is seen, and this is the aorta, and you see there's a BSD. So every view you can take, this is the RA, this is the RV, this is the LA. You see the LA is always behind the aorta. This is the aorta, LA is always behind this. You see, this is LA, aorta, RA, interatrial septum, RV, and the pulmonary artery will be here. So you can see a BSD here. So the summary of 2D findings is a large male-aligned and non-restrictive, explained to just now, non-restrictive, it is a BSD. It is a large membranous. Why we say male-aligned? Because it was not aligned with the septum. You can see it is not aligned with the septum. So it is a non-aligned, but it is a membranous BSD. And large aorta with aortic override. These two things will show you just now. So any doubt till now? Because these are the four things you must see in these cases. So So now we come to, after color, we come to color. The role of color is always the type of the shunt flow, because whether it is right to left, left right or what, it helps in localizing the RVOT obstruction. How? We'll show you. We say, wherever there is an obstruction, there will be a sort of a different type of flow, what is known as a turbulent flow. The turbulent flow is a mixture of the colors, and then it guides the Doppler beam parallel to the flow. So that is the, if you have asked the main thing, the type of shunt flow, localizing RVOT obstruction, and guides the Doppler, because you can see the flow, you can put where to put the Doppler. Now see, so you see, this is the transducer. Any flow going toward the transducer is of a red color. Any flow going away from the transducer is of a blue color. So you can see, this is the LV, this is the flow going toward the transducer from right to left, and this is the blue coming back. So this is what is known as a bidirectional shunt. You see, and you'll understand it better here. You see, this is the red flow going from LV to RV, and this is a blue flow coming from RV to LV. So this is producing a cyanosis also. So this is the advantage of a color flow mapping. It tells you that what type of shunt is there. In many cases, there may be purely right to left shunt, but usually it is bidirectional. Then the most important thing is in a fellow tetralogy pulmonary obstruction, say the right ventricle is connected to the pulmonary artery. Now, when there is an increased pressure, and when there is a pulmonary increased pressure to the flow, the RV pressure increases, because RV has to push a blood through a narrowed orifice like aortic stenosis. The pressure is more in the LV. Mitral stenosis more in the RALA, because it has to push the blood through a narrowed orifice. So because it has to push the blood through a narrowed orifice, so the RVOT obstruction increases. The more the RV obstruction, the greater will be the RV pressure increase. So if there is a greater RV pressure increase, it can produce a sort of a cyanotic reversal of the shunt also. Because sometimes in very mild pulmonary stenosis, there may not be cyanosis. So that in the earlier years was known as a pink fellows. Pink fellows mean that they are all the features of fellows, but they were not cyanosed, because there was a mild thing, obstruction. So the greater the obstruction, the greater will be the RV pressure, the greater will be the shunt flow. So this is usually in fundibular, valvular, and both of them combine this. So this is sort of a RVOT obstruction in these cases. So I told you why it is more important, because it determines the extent of the RV pressure. Now you see here. Now this is the short axis view. This is the LA. This is the RA, RV, pulmonary artery. Now you see, this is the infundibulum. Infundibulum is the tube-like structure which goes into the outflow of the pulmonary artery. So this is the pulmonary artery. And you see here, there is an obstruction of the infundibular region. This is known as the same thing. It is known as the outflow, or it is known as infundibular. So you see, it is marked hypertrophy, and there is a obstruction here. Now see the color. Now you see, it produces turbulence here. The valve is here. It produces turbulence here, much before the valve. So that means there is a fundibular stenosis, because we always see which is the point of obstruction, point of turbulence. A point of turbulence is here, much beyond the pulmonary valve. You see here, it is completely shutting down the infundibulum. So this is producing a stenosis. So, and you see another patient. This is LA, RA, RV. You see here, there is a pulmonary artery, and you see a membrane. You see a membrane into the pulmonary artery, and this is the pulmonary artery, the pulmonary wall, and this is the pulmonary membrane in the infundibulum region. Will show you again. And then this is now here you see this is the. So you see now here the stenosis is at the valvular level because here there is no turbulence. Remember that any time a blood flows towards a narrowed orifice, there's a in acceleration of the flow. So this is not a turbulence, this is a flow acceleration, but real turbulence starts here. You can see at the so this is a valvular stenosis, not an infundibular stenosis. You will see more examples of infundibular stenosis. Now here you see this is a normal pulmonary wall. You see this is the left atrium, aorta, RA, RV, pulmonary wall. There is nothing in the pulmonary artery here. It is just a normal opening of the pulmonary wall and the pulmonary artery is clear. But here you see there is a membrane behind the pulmonary artery that is supravalvular membrane. It won't stop. See, this is the pulmonary wall and this is the membrane. So this is supravalvular membrane. So this was not seen earlier. So this in the previous one it is not seen. This is very clear. But once you come here, you see this membrane. So this is the supravalvular stenosis. So like aortic wall, whenever you see any aortic stenosis, you see from supravalvular, valvular, and subvalvular the same thing. Why I brought it here? You can see just once in a while. You can see you are seeing more of it now. So the color flow mapping you have seen that what we see is the turbulence both at the subvalvular region and at a valvular region. The Doppler field, this is a normal VSD. This is normal VSD. The flow always goes from a high pressure to a low pressure chamber. In a normal VSD, the LV pressure is more than the RV. You see the LV pressure is more than the RV. So the flow is a high velocity flow is from the left ventricle to the right ventricle. You see this high velocity flow. But in fellows, what happens? It is a low velocity flow because here it is known as a unrestricted VSD because it is a very small VSD. But here it is a large VSD. Now, if you take a room with a door, when the door is fully open, 5-6 persons can pass easily through it. If the door is closed, partially closed, you require more pressure, there will be obstruction. So here, because the RV pressure is also increased because of pulmonary stenosis, so you see there's hardly very low velocity flow. Very low velocity flow. Now here you see it was coming to almost 120 millimeters of mercury in a normal case. Now here it comes about 18 because it is a free flow from the LV to RV through a large VSD. So it is because it is an unrestricted flow. So it is low velocity flow because the RV pressure is also increased. So that is why the reason that you don't get a pure high velocity flows. So in fellow tetralogy, this is an aortic override which we showed you. VSD, right to left shunt or bidirectional shunt with an RVOT obstruction. RVH, low velocity VSD flow and turbulence in PA at high velocity flow. All these things you have seen in the fellow tetralogy. 1, 2, 3, 4. That is the tetralogy 4. Now you see. So you see again, there is an aortic override, just a summary aortic override. Then there is a large VSD, aortic override. Then you see a shunt, bidirectional shunt. Then IVC, RVH will show you. And you see a turbulence here with high velocity flow, turbulence. Because it is high obstruction, you put a CW Doppler to see the velocity. another variant, you see. So this is a parasternal long axis view. You see aortic override. You see a large VSD here, and you see again a bidirectional flow going from right to left and left to right. So the bidirectional flow. So all the features of a fellow tetralogy. You see the turbulence again. Now you see the turbulence in the infundibular region again. You will see a lot of turbulences. Now this is a sometimes it can be combined, but you see this is a membrane, a turbulence. So you have seen aortic override, you have seen VSD, RVH, and a pulmonary stenosis. But this patient has the ASD also. This is LA, this is RA. You see a flow. So it becomes a fellow's pentology. Pentology means that there are five, besides the four, the five things are there now. But one thing is more added, so it becomes a fellow's pentology. So that means you have to go and see every structure you have to see. Now, this was a 19-year-old boy. He came to emergency in a very serious state, very drowsy, unresponsive, septicemia, and very other thing also. Oxygen saturation was only 73 and tachycardia was present. And see, there was a marked cyanosis and clubbing. And you say the typical features, a marked RBH. एक मिनट, हमारा लेक्चर चल रहा है हमारा लेक्चर चल रहा है अच्छा So, so see, there is a very marked RVH because of a pulmonary hypertension and increased RV pressure and all these signs. And you see this is a marked RVH. This is the RV, and you see this is the LV. RV, and RV is a large and LV is small. You see LV small in relation to RV, and you see this is RVH. There is no aortic override or nothing. The area you see. And here you see the same M mode, you see the large RV, and you see the RVH is present. It is about 12 millimeters, normally less than 5. And that is the paradoxical septal motion. Here the systole comes here. Here it is systole the posterior walls, all just to show that what have you seen a 2D echo, you see in M mode, the RV or LV present, or you see the flattening of the interventricular septum indicative of a marked RV pressure because it is a pressure overload situation. And again, you see here, you can see a membrane into the infundibular region. So this is the LA, aorta, a interatrial septum, RA, RV, and see a smart. And you see marked RVH, and this one see just now. Again, you see a static image. This is the pulmonary wall. This is a membrane in fundal region, and this is the marked RVH. So that is, this patient has a pulmonary stenosis, severe pulmonary stenosis, RVH. Then we'll show you. You see now, marked RVH and this membrane in the infundibular indicative of a infundibular stenosis. And you see there is a severe pulmonary stenosis infundibular with a 77 mmHg. And the same patient who showed earlier, same patient, you can see a shunt from here to from the RA to the LA. So that means there are three things in this patient. He had a marked pulmonary hypertension, he had an ASD, and he had a significant RVH. So this patient was usually labeled at earlier as a triology of fellows, but nowadays we call it as a severe pulmonary stenosis with the right to left shunt through an ASD. Because in fellow there should be aortic overriding. So in this patient there was RVH, severe pulmonary stenosis, and the right to left shunt through an ESD. So this was known as a severe pulmonary. So you have seen all varieties of this, of fellows you have seen. So you have seen the typical fellow, you have seen the pentalogy, and you have seen this triology also. Any clarification before you go to the next topic? Any questions? Are all of you awake? Karina?
Sir, I have one question, sir. I didn't properly understand what overriding is, sir, exactly.
Say overriding, you see, say this is normal VSD, this is LBRV, this is VSD, but the aorta is normal. But in this, what happened now, you see here, in a normal situation, what you see, this is the aorta, this is IVS. So they are in one connection. The aorta and the IVS are in one connection, like a mitral and the aortic junction. In an overriding means it overrides the septum, overrides the. So you see here it is the same. They are anatomical in one line or so. But you see here you see it is not even, it is overriding this is overriding. It was not overriding. This is the, in one situation, the same continuity between the septum and the antivolar aorta. But
Yes.
here you see it is an overriding. It is overriding the septum. Can you see this overriding?
Yes, sir. Yes, sir.
So this is over. It is not in connection with this. It is not in connection with VSD or septum, but it is overriding. So this is the overriding of the aorta. Here you don't see. You see. This is a VST, but there is no overriding of the aorta. So this is a pure VST. So again, you see the overriding of the aorta. See, this is the aorta should be in this line, but it is overriding the VST. So this is the aorta overriding. Anybody else? Any question? So you are clear about overriding? And
Yes,
the
sir.
name
Yes.
says overriding.
Yes, sir. Sir, is there any gradient criteria to say that this VSD is of low flow velocity?
Oh, yeah.
Or
Say it is. Normally, there is a question. Normally, it is very. We can calculate RV pressure from a VSD flow
yes, sir.
normally. But here you see it is a very high velocity flow. In a normal individual, you can see the LV pressure is much more. It is a difference of pressure between the two chambers. And how we calculate the RV pressure? You take the blood pressure of the arm, which is indicative of a left pressure, and you subtract from this. You take the blood pressure and subtract the gradient, so that will give you the RV pressure. Because it is between the difference between LV and RV. LV is although you have taken by a sphygmomanometer and this. So this you see it is high velocity flow because it is a narrow orifice, very narrow orifice also. But here you see there is a very low velocity flow. It is hardly 2.1 meter per second, because indicative of a very unrestricted VST, because it is free flow from the both of them, and that is why they call it unrestricted and very low velocity flow. That will present in every case also.
Okay.
Any other? So this was a 27-year-old female having dyspnea, cyanosis, clubbing. You see, a 27 fate. Now you see in this case, and you see There is a large VSD, but there is no aortic overriding. And there is a marked RVH, because RV is anterior. Everything toward this transducer is anterior. So you see a marked RVH, and there is a large VSD, and there is no aortic overriding, and there is a small LV because there is a large RV also. Now, then you see in this you see there is mostly the flow is from right to left. Mostly the flow is from right to left, indicated this giving a right to left shunt or so like this. So this patient had a till now marked RVH and with a VSD and a right to left flow. So, and you see once you give a contrast, it goes to the right ventricle. From the right ventricle through the VSD, it goes into the left one and then goes into the aorta. It shows the predominantly right to left shunt. This is only for demonstration, although we had seen from a color also, but we can see from the demonstration also. So this was the case of an Eisenmenger syndrome or disease. These are a group of shunt lesions with severe pulmonary artery hypertension leading to bidirectional reversal of the shunt. So when there is a significantly increased pulmonary artery hypertension, it leads to a reversal of the shunt because any long-standing untreated congenital cardiac defect lead to pulmonary hypertension and cyanosis. That is why we don't allow many of these patients to go to a long stage of a pulmonary hypertension. So it is mostly with an ASD, VSD, or non-restrictive PDA. By VSD, when it is more than 15 millimeters or so, and more common in VSD. So that these ASD, VSD, and the PDA, when they develop a severe pulmonary hypertension with reversal of the shunt, that is known as an Eisenmenger syndrome. So that they have got an irreversible pulmonary artery hypertension. So the most common is a VSD, but you can see in any of these also. So this is a Eisenmenger syndrome because of a long standing. It is usually found in young females, and when you see them, you'll find that there is a marked pulmonary hypertension and right to left shunt and this. So now we come to that was a simple thing. If we come to a transposition of great arteries, telling you concordance and discordance. Now suppose this is a normal tongue. Now this is inferior vena cava, superior vena cava. A concordance means normal connection. Discordance means abnormal connection. So you see here the SVC and IVC come to the RA. From RA they go to the RV. Now from RV, normally the pulmonary artery should come, but here it comes, the aorta comes. Similarly, left side, the pulmonary veins, they drain into the LA. From LA, it goes into the LV. From LV, it goes through the pulmonary artery, not into the aorta. So this is known as an atrioventricular concordance. R is connected to RV, L is connected to LV. So this is atrioventricular concordance, but ventriculo-arterial discordance. So this is a ventriculo-arterial discordance. So just remember, concordance is normal. So because the RA is connected to RV, so atrioventricular concordance, and ventriculo-arterial discordance because the aorta is coming from RV. So this is what we see in the transposition of the great arteries. Aorta rises entirely or in large part from morphological right ventricle. PA rises anteriorly in large part from the left ventricle. So there are two separate parallel circulations. Now we'll come to this for here. Now in what we have seen now, the vena cava, they drain into the RV, RA. From RV, they go to the RA, and from RV, they go to the aorta. Now this is a cyanotic or a venous blood. And here you see pulmonary veins oxygenate, but these are parallel circulation. A person or a child cannot survive if he or she is only getting a venous blood. So there has to be a mixture between these two. So it can be at the atrial level, ventricular level, or a PDA. So there has to be a communication between the venous and the oxygenated circulation to survive the child. So now you can see here, one circulation is this: LA, LV, pulmonary artery, pulmonary vein, and then LA. Other is IVC, SVC, RA, RV, and aorta. Systemic. So there has to be some communication for them to survive, and they are mostly ASD, VSD, and this. So they are such a severe condition that many of them die. Now, what they used to do, that whenever a child of TGA was born with severe cyanosis, they used to create an ASD, both in the department itself, echo. When they create an ASD, so that in the blood, when they create an ASD, so this thing happens and the child tries to survive or so. So there's an AV concordance and VA discordance. That means, as I told you. So we have to demonstrate this. Remember, any great artery that does not bifurcate, is the aorta, and the artery which bifurcates so because the aorta rises from the RV, so this which does not bifurcate, but the artery which arises from the other chamber, it tends to show a bifurcation. Now see, this is now what happens that normally what happens, the aorta goes anteriorly toward the neck. So the aorta is mostly directed towards anteriorly like this. So because you have seen neck vessels or artery vessels normally go this. A pulmonary artery usually goes behind like this. And now we go artery. Now you see, this is how you can see how the difference of imaging was. This was done by Dr. Gupta 22 years back. You can see how the machines have differed. Now you 22 years back, an infant, you see the artery goes posteriorly. Here it goes anteriorly. If you see a short axis view, the artery goes posteriorly here. But we still do not know whether it is a pulmonary artery or not till we show a bifurcation. And from this, we show a bifurcation. You see. Now this shows bifurcation. So that means this is the pulmonary artery which arises from the left ventricle. So there must be a communication. So the communication is as an ASD. You see the ASD. So we got from 2000, so that's why you have seen the artery going posteriorly, showing a bifurcation and an ASD. Now coming from 2003 to 2024, one of our cases, you see, this is a subcostal view. This is the RV, LV. This is a modified view where we put the blood vessel. We see one blood vessel coming from RV, one blood vessel coming from LV. So we do not know which vessel is what. And there's a VSD here. So there's a VSD here, and you see one artery coming from here and one artery. This is how you have to manipulate the transducer. As I told you earlier, you can, in an image, never remove a transducer. It is sliding, angulation, and rotation. If you remember these three things, you will never miss an imaging. So you see, this is the. Now, when we put a color, still we do not know. One artery coming from this right ventricle, one coming from this. This shows a bit of turbulence. No, but still, although we know that it should be the pulmonary artery, but we have not shown the bifurcation. So this turbulence is possibly because of pulmonary stenosis, but we have to show a bifurcation. So this is the aorta, this is pulmonary artery, or one great artery, another great artery. We don't say aorta, pulmonary, till we say two great arteries. Now here you see, we can show a bifurcation. One branch goes here, one branch goes there. So now we can say that this is a pulmonary artery arising from the left ventricle. Well, we have shown the bifurcation now, and which was not shown earlier. So, and you see, and then when you put a CW Doppler, you get a severe pulmonary stenosis with a gradient of 105. So again, you see here, we can see the turbulence. This is the aorta coming from the RV. This is the pulmonary artery coming from the LV. But we have only when we have shown the bifurcation, then we can say that it is a TGA. So bifurcation is very important also. So there is an AV concordance as we showed you. VA discordance demonstrate abnormally connecting connection between the ventricles. LV connected to a great artery that bifurcates in two branches as we showed you. That LV connected to artery which bifurcates into two branches, and RV great artery that does not bifurcate. Presence of ASD, BSD, PDA. Now, any questions till now? Or after the next present, now this was the TGA. This is something known as the this is also you see. We see these cases, you will also see this is a congenitally corrected TGA. Now you see. In this, the R is connected to LV. So that means there is an atrioventricular discordance, correct? And the LV is connected to pulmonary artery. So that means the ventricular arterial discordance, both. On this side, LA is connected to RV, atrioventricular discordance and ventricular arterial discordance. So this is a concordance and discordance, a complete discordance between RA and LV and here. So you see, now you see this, I always bring this slide. Now you see the tricuspid wall. As I have been told to you, the tricuspid wall is more attached superiorly toward the apex. So you see, this is the mitral wall. This is the tricuspid wall. Tricuspid wall is arising from here. Mitral wall arising from here. So this is more coming out from the apical view. So the wall, atrioventricular wall, which comes from with more toward the apical view, is the tricuspid wall, and tricuspid wall is always connected to the right ventricle. Remember this thing. Again, you see, mitral is arising from here, tricuspid is arising from here. So there can be a difference of 5 to 10 millimeters between their origin. So you can again you see a moving one. This is the mitral wall, this is the tricuspid wall, and this is RV. So now you see this is LV and this is LA. Now see this thing. Now this wall is arising more towards apical side as compared to this. You can appreciate this. This is arising from here and this is arising here. So this has to be the tricuspid wall. And the tricuspid wall is always connected to the right ventricle, which is enlarged. And this is the mitral wall. So now we have to show that this is the LA. Now we have already seen that the pulmonary veins are draining into the LA. So that means this should be an LA. So that means the LA is connected to the RV, that the atrioventricular discordance. RA connected to LV and atrioventricular. But we have to show it. So you see here. Now you see the pulmonary. We have to show that pulmonary veins are draining into the LA. So you see this is the pulmonary veins draining into the LA, and from the LA it goes to the RV. You see here. And here you see the PA arising from the left ventricle. So this is an atrioventricular discordance, ventricular arterial discordance. And why the RV is enlarged? Because this is supplying the blood to whole of the body. RV is connected to the aorta. That means this ventricular arterial discordance. So you see, so it is supplying, there is a lot of strain on the right ventricle, and any strain on any chamber increases in size, and ultimately they go into failure. So why these patients are now why their patients are all right? Because the venous blood goes from RA to LV. That's the venous blood. This called, and it goes to the pulmonary artery, and it gets oxygenated blood. So the oxygenated blood goes into the LV, oxygenated blood goes to the RV, oxygenated blood goes into the aortas. So there is an oxygenated blood now. So that is why many of these patients, if they have got no other associated defects, they can live up to quite a bit of an adult age, because this is known as a corrected transposition. It is the transposition is there, LV, pulmonary artery, and RV to the aorta, but it is corrected one that there is no cyanosis, and because of this reason. So, any clarification? Because you are reading for the first time, so you have to go on revising.
Good evening, sir. Sir, can you explain again difference between concordance and discordance?
Concordance means a normal connection, correct? Discordance means a abnormal connection. When the see, now here RA is connected to RV, so there is a normal atrioventricular concordance, because this is the same thing. But here the aorta is arising from the right ventricle, so this is a discordance. That means ventricular arterial discordance. So discordance means abnormal connection. Concordance means normal. Correct? So here you see LA is draining into the LV, normal atrioventricular, but the pulmonary artery is arising from the LV instead of the RV. So this is ventricular arterial discordance. So remember, discordance is abnormal, and concordance is a now. So what the case I showed you, the RA is connected to LV, correct? So this is the atrioventricular discordance, because RA should be connected to RV, and LV is connected to pulmonary artery, so that's a ventricular arterial discordance. So concordance means a normal connection. Discordance means an abnormal connection. When we say ventricular arterial discordance, that means the arteries are not arising as they are expected. When we say atrioventricular discordance, that means the atria and ventricular are in the opposite connection. So this is concordance and discordance, normal or so. Any other? Any clarification? Okay. So now we come, this is also we see quite frequent in adult age, that is Easton's malformation. Now, we are showing you more of an AV images. Theory you can always read. So get a mental idea of this. And for God's sake, revise. When you don't, if you want to see any image again, when you come on hands-on training, you can ask that we want to see it again. Or in between, whenever you want, you can contact us, we'll show you. Now, instance is about 1% of CHD. There is an apical displacement of tricuspid wall leaflets, septal and posterior from the atrioventricular ring. Atrioventricular ring is there from where the atria and the ventricle join together. Now we see. Again, normally, now when wherever you put a transducer, you can see a transducer, but I'll not confuse you. Now you see. In a normal individual, you see this is like I told you, a mitral wall, aortic wall. You can see there is an attachment of hardly difference about 5 to 10 millimeters. In Easton's anomaly, is the marked displacement of the septal of the posterior leaflet apically. So here you see, instead of rising it, can you see this? It is rising here. This is the septal leaflet. Instead of arising here, it is arising there. Again, see, so that you don't get confused. It is arising here hardly few millimeters, but here it is there. So it is said when it is more than 8 meter square, it is suggestive of a marked displacement, or when it is more than 15, 16 millimeters. You see. So this is the septum, this is the same view, but the marked displacement of the leaflets. Here you can see better, you see. The tricuspid leaflet, septal leaflet is going anteriorly, almost about 26.5 millimeters instead of 5 to 10. So there is an apical displacement of the leaflet toward the apical side, which is abnormal in these cases. A normal can be about 10 to 15 mm also, but here it is almost 26. So there is one thing. Then there is a enlarged anterior leaflet, enlarged like a sail like. Again, you see, I'm always coming to this one, normal. Septal anterior leaflet, this is the anterior leaflet. A small anterior leaflet coming, moving here and there. This is the septal and anterior. Okay. But here you see, a large anterior leaflet. Like you see the sail of a ship, it is known as a sail-like motion of the anterior leaflet. Here, you see, this is anterior leaflet, correct? When instead of a small anterior leaflet, you see it is coming here. So you can see the septal or the posterior leaflet is markedly displaced toward the apex, and you see the anterior leaflet is very prominent or sail-like. Then what is atrialization of the, now this I will also show you the atrialization. Now you see, you have seen the displaced tricuspid leaflets. Now RV is divided into two parts, the distal small ventricle and this is the atrial. Now, I'll show you this in a better picture here. And you see now, again you see, this is the anatomical tricuspid wall and this is the whole of the RV, which is not divided into two parts, but it is a single chamber of RV. But here you see, so atrialization, the portion, this is the anatomical annulus and this is the functional annulus. Functional annulus means that it has just forming here because they are transparent. Annulus is usually where the leaflets are attached. So you see this portion, so that is known as an atrialized right ventricle because it gives an electrical impulses of the right ventricle. This is known as an atrialized. I'll show you again. Now see, this is the whole is atrialized. This is the small RV. So this is the true functional RV. This is the atrialized. That means that this only looks like an atrium, but it is between the anatomical annulus and the functional annulus. So this is the atrialized right ventricle. So again to show you, the atrialized and the functional ventricle, which is small, and this electrical. Now you see here, there's only single chamber because this is known as the anatomical annulus. You see, this is atrialized RV, this is anatomical, this is functional, and this is the portion is known as a atrialized right ventricle. And the tricuspid regurgitation. So this is the apical displacement of leaflet with a large anterior leaflet. And tricuspid, now in a normal individual, the tricuspid arises from this is TR. This arises from the anatomical annulus because this is the normal that the leaflets are here, it arises from here. But in Eastern, the leaflets are going up to this place. So you see, the TR is coming almost from this place. Instead of this place, it is coming from this place. This is an apical tricuspid regurgitation. Because the regurgitation always comes from on any leaflet, MR from mitral wall, TR from this. So this is an apical tricuspid regurgitation. Now this is another you see, another you see, very advanced stage or so. You see this is the displacement of the septal leaflet. You see there is a very large tricuspid anterior leaflet, and this is the atrialized portion. You see, this is the atrialized RV, and this is the small RV here. So that is just there. So there in 90% cases, there is a, you see again a ASD. You see flow going from LA to RA. You see this is a large RV, large RA. This is a anterior leaflet, this is the septal leaflet and the flow going. So this is an instance with an ASD. So summary, apical displacement of the septal leaflet, sail like prominent anterior leaflet, atalized right ventricle in this point, TR coming from apical side, ASD, VSD, or what we have seen as the RV volume overload. So these are the features of this instance. Any clarification? Either you have understood nothing or you have understood everything. So I will say that if you spend about 30 minutes today or tomorrow, read these and keep these images in your mind, you will not, you get a permanent thing here. Tricuspid atresia, you will see, we see quite a bit, you will also see. Again, atresia means absent, hypoplastic means small or underdeveloped. So when we say tricuspid atresia, that means there is an absent tricuspid wall. When we say hypoplastic, it is small or underdeveloped. So here the tricuspid valve is absent, RV is hypoplastic, main chamber is LV, which shows a compensatory enlargement. And there is no communication between RA and RV. There is an echo dense band. Now, how do the patient now again here not you see absent tricuspid wall, small LV because RV is not getting blood from the RA, so it is underdeveloped. It's not getting a proper nourishment, so it is small or underdeveloped. And you see there is a tricuspid wall is absent, and there is no communication between RA and RV. So now you see. So you see the blood from the IBC and IBC coming to the RA. It cannot go to the RV because of atresia. So how will the blood cannot continuously remain here? So there must be a ASD here so that blood goes from RA to LA. Otherwise, the patient cannot even live for a few seconds also. So you see, it goes to the RA. From RA, it cannot go to the RV because there is atresia. It has to go through an ASD into the LA, and then it goes into the LV. And from here, there has to be a small VSD so that the blood goes from LV to RV for oxygenation. So you see how here the oxygenation is 60%, here is 95% pulmonary veins or so. So that you will see now. So again, you see, I always try to this. Now you can see the tricuspid wall. You can see this tricuspid wall. This is that is why whenever you see an apical view, always see that both AV walls are present or not. Make a mental picture of this. Now see here. There is no tricuspid wall. You will understand it better. This is your view. This is now you see, this is a absent tricuspid wall. This is RA, LA, and this is hypoplastic right ventricle. And this is the main one left ventricle. So coming to my view, so again, this is the normal one. This is the RA, this is LA, LV, mitral wall, a hypoplastic right ventricle. You see hypoplastic, there should be some sort of a, so the flow, there has to be a flow from RV to RA. Otherwise, there from RA to add blood in this. So you see, this is your view. Who keep LV on this side, again the same thing. A shelf-like complete absent tricuspid wall. So again you see, same thing. And now you see, here you see the pulmonary veins come into the LA, here. Here see the pulmonary veins coming. But here we can't show a a shunt. But from where is the shunt? We have to show a shunt from the RA or LA, but we cannot show it. We're only showing that this is the LA and this is the LV. We cannot show anything else. So we do a contrast echo, and now you see it goes into the RA. From RA it goes into the LA, and from LA it goes into the LV, and here you see. So this is the value of because these are adult patients, the value of a contrast echo, RA, LA, and LV. The same thing you can see here. You see, RA, LA, LB. So this is how we show the head to right to left shunt. Another patient, you see, it looks like the complete IES is intact. Now this is either an station wall or a Shari network, any worm-like structure into the RA. So you see here, now this is your view. You see the structure into the RA, which usually the station wall, and your enteroatrial septum appears to be fully intact, you see. And this is your LV, and this is a hyperplastic RV. Very small, very small. You see, again you see. So you see as if there's a complete formation of the IES, but how can the child survive? Mitral wall, LV, and a small hyperplastic RV, and complete absence of the tricuspid wall. You give it a contrast, goes from RA to LA, and also goes into the RV. So you see the blood from the LV goes into the RV, which is an obligatory shunt so that some of the oxygenated blood can come. So it goes into the RA, LA, LV, and this. So this is and that we always see for other lesions also, VSD. So an absent tricuspid wall, hypoplastic RV, large LV compensatory, prominent one AV wall because one is absent, one prominent AV wall, which is mitral, ASD and VSD, what we have shown, and other associated lesions. Any clarification? Clear? So this also we see quite even in adult age we see. All hearts with atrioventricular connection to one main chamber is a single ventricle or a univentricular heart. It can be well-developed LV or RV or any other intermediate chamber. That means a chamber receiving both the tricuspid and mitral wall. There is no septum, but a chamber receiving more tricuspid and mitral wall and in one chamber. So it's again, I bring to normal, you see. Mitral tricuspid, there is a this LV mitral wall opens in LV, tricuspid opens in RV. And you see there is nothing in between the two, the septum. But here you see, now what we say, a diastolic kissing of the atrioventricular walls. You see here, you see, both of them are moving, but separately also. But here you see, there is a single chamber, and both of them are moving, and there is nothing stopping them. So we call it a kissing atrioventricular chamber. A wall will go into this, a single chamber. And here you see both of them. And you see blood going from both the chambers into the single chamber. So that is univentricular heart. There is nothing stopping them. Both the flood, both going in a different direction, but without any hindrance also. So this is a univentricular heart, and most of the time, it is associated with a severe pulmonary stenosis, and we can see a turbulence into the pulmonary wall. So that is just, you can just keep in mind that you see always that now sometimes this is known as a, now it is difficult for you. This is known as a complete endocardial cushion defect. A single wall like this, a common wall, it can be mistaken actually for a univentricular heart. And this is ASD, but not going to this. Now almost the last one, anomalous pulmonary venous connection. Now normally, you know, the pulmonary veins drain into the left atrium. That is a normal, if you are not forgotten the anatomy. In this patient, in this case, what happened? All pulmonary veins drain either to left atrium or right atrium or any other systemic vein. Majority of symptoms, more 80% are left untreated. So forget about partial. All pulmonary veins drain into the right atrium. So there is a marked enlargement of the right atrium. Why? Because it is getting a flow, extra flow, one flow getting from the IVC, SVC, and extra flow coming from the ASD. So this, like any ASD, there is a marked enlargement of the right atrium. The RB is enlarged, the same thing like any ASD. Small LA. Why small LA? Because all the pulmonary veins are draining into the right atrium and nothing drains into the left atrium. So that means that it is a small one. And they usually present with cyanosis in infancy and failure. So these are, well, just really all four veins connected to LA, they join together to form a venous confluence, and then they go to a RA. So it is very rare, and experience is relatively small because it only used go up to the adult age. But luckily, this was a 9-year-old boy, economically poor, breathing difficulty on exertion. He used to get fever, given antibiotic treatment, last 4 months, mild cyanosis on lips and exertion, and then medical attention was sought. So that means he went up to 9 years, and then he developed the symptoms, and there was a mild cyanosis on the lips, on exertion that too. And when the medical attention was sought, and the IEC showed RVBB. Now, you can see the enlarged RV. This is a parasternal long axis view. You can see increased RV. Now this you will also show again. Now this is RV, LV, RA, LA, large RA, small LA. And you notice this thing. I'll show you better again. This is a channel coming in between the LA. This is known as the venous channel. You'll understand it better later on. So you get small LA, small LV, large RV, large RA, and this is a venous channel in which the whole pulmonary veins drain. Now I'll show you again. This is a normal one. Now here you don't see any channel or anything. The whole of the LA is clean with no other membrane. But here you see this one. So this is a venous channel in which the pulmonary veins are draining. And you see, none of them going into the LV. All the blood is going into the RA-RV. You see here. This is the venous channel, the pulmonary veins draining into it and going directly into the RV. I'll show you better now. This is a normal one. This is usual ASD, in which from the pulmonary veins blood goes to the LA, from LA goes to the LV, and also the blood goes into the ASD. But here you see, no blood goes into the RV, LV, and all the blood goes directly into the RA and RV. That means all this is connecting to the pulmonary veins here. Now, what do they do in these cases? Number one, they close the ASD, and then they establish a communication between pulmonary vein and LA. Because till now, what was happening that the pulmonary veins were draining only into the RA, not into the LA. So you see here, now you will see better this thing. Now this is RV, RA. This is the closure of the ASD. And now you see this venous channel. And this is the communication made between the venous channel and the LA, which was small. This is the channel made. So this I was telling you is the venous confluence or the venous channel. So now what will happen? The blood from the pulmonary veins will go into this venous channel, go into the LA, and from LA it will go into the LV, and ASD has been closed. So you see, now it is going into LA. By modifying the transducer, it is going into the LV. So it is always this is to be used to show that from this communicant, it is going into the LA now. Now, is this communicant by slight modification of its transducer, you can show that it is also going into the LV. And no blood is now going into the RA also. So this is now you can this is the best view of the venous channel. I showed you the now you can see much better. This is the venous channel, and this is the communication which has been done. So, in summary, always evaluate clinically ECG, X-ray, chest. No basic anatomy and hemodynamics. Without that, you have nothing. Have a lot of patience because in an infant we have to call them repeatedly many times because we don't know what happens here. This is aortopulmonary window. We don't want to bore you with this aortopulmonary artery. And go stepwise, good sedation. Always look for a right to left shunt. Try to see for multiple defects. Use contrast echo if need be. Then we call a White syndrome sometimes that if you see an abnormal thing, for example, you see here, this is a patient of a pericardial effusion. But why the RVs are large? You see, and there is a sort of a volume overloading of the LV, flattening of the septum. So why should the RV be large in these cases in a pericardial effusion? So when you go here, you see a Easton's anomaly. You can see now that was the cause of this. You can see large anterior leaflet and the marked displacement and atrialized septum. So always look very carefully and then go. But you must know the anatomy also. This I always show for the mothers only because we are dealing with congenital heart disease. Every artist gives his own name to his work, but there is no artist like a mother who gives birth to a child but gives a father's name. The most beautiful necklace a mother can wear is not a gold or gems, but a child's arms around her neck. So this is what we do, and that go to my final guide to you is that it is not a difficult subject, but it is difficult for you. Read the basic when you go with it today or tomorrow. Make a small note, fellow tetralogy, 2D, this, Doppler, this, in about 15 lines. TGA, what? Easton's anomaly, what is 5 anatomical points, just, and then remember these images, and then if need be, we can show you again. So any final question or no? But definitely, if you don't read within a day or two, you'll forget. And then we can tell you these images also.
Thank you, sir. Any questions from anybody?
Say the questions you can answer because actually my brother is critically ill. So I was only wondering that he survives so that I can give a topic or so lecture. So you can I'll discuss with him and then we'll see. So आप अगर question हो तो आप ले लेना. Anything you want to see? Any image you want to see? Or
Anybody,
you
any
recollect?
amazing?
But we'll show you these images if need be when you come for a course or anything. But don't leave everything for the hands-on. Because the hands-on, it is mainly hands-on, not much lectures also, but revise and make notes also.
If there's no more question, let me take an attendance if it's possible. So I'll just call the roll numbers and please say yes or no if you're present or not. Okay, let me go ahead and take attendance. Roll number 1,
Present, sir.
2,
Present, sir.
3, 4,
Yeah.
Present, sir.
5,
Present, sir.
6,
Present, sir.
7,
Present, sir.
8,
Present, sir.
9,
Present, sir.
10,
Present, sir.
11,
Present, sir.
12,
Yes, sir.
13,
Present, sir.
14, 15,
Yes, sir.
16,
Present, sir.
17,
Present, sir.
18, 19,
Present, sir.
20,
Present, sir.
21,
Yes, sir.
22, 23,
Present, sir.
24,
Present, sir.
25, 26,
Present, sir.
27,
Yes, sir.
28,
Present, sir.
29, 30,
Present, sir.
31, 32,
Yes, sir.
33, 34,
Present, sir.
35.
Yes, sir. Present, sir.
Dr. Samu. Okay, thank you, sir. Dr. Samu.
Yes, present,
So
sir.
absentees are roll
Yeah.
number 3, 14, 18, 22, 25, then 29, 20, 31, 33. 1,